Good morning all, and I'll be presenting uveitis and multiple sclerosis in Indian population. So these are series of representative 4 cases. The first case, it's 49-year-old female, and all the cases have presented with anterior uveitis symptoms like photophobia, redness, pain, and decreased vision. But priorly, she had left eye optic neuritis in this left eye optic neuritis and MRI brain and spine revealing demyelinating lesions, which are periventricular T2 hyperintense. And in all these cases, lab workup was negative for all infections like TB, sarcoid, and all autoimmune profile like SLE, Behçet's. And this is the presentation. It was bilateral granulomatous anterior uveitis, and with all granulomatous KPs here. Granulomatous KPs with some corneal haze, broad posterior synechia with complicated cataract. This is fundus picture with mild vitritis more in the right eye and in the left eye. So this picture onto the left is granulomatous KPs in one of those recurrences post cataract surgery. We treated with oral steroids, but she developed avascular necrosis of hip. And so she has to be switched to mycophenolate mofetil 1 gram BD as steroid sparing agent, and in 2 months she shows good response. This is another case, 18-year-old female presented with granulomatous anterior uveitis and pars planitis with peripheral vascular sheathing. In this particular case had neurological symptoms like numbness in right big toe and muscle fatigability after aerobic exercise, which is Uthoff's phenomenon. And the neurologist has treated this particular case with subcutaneous beta-ferron injections for 1 year. And also we did mycophenolate in this case. But 4 years later, she develops ICE kind of syndrome with iris atrophy and choroctopia. And she, with uncontrolled IOP, she undergoes TRAB, which fails, and then AGV with PKP. This has been treated with MMF and showed good tolerability and response. Again, the follow-up MRIs revealed decreased enhancement and also decreased in the number of lesions. This is another case, 38 female, again left eye optic neuritis, but in this particular case, MRI brain was normal except for the thickening of optic nerve. And interestingly, CSF revealed oligoconal glands, which were included in the recent criteria for diagnosis of MS. And 10 months later, she developed acute granulomatous anterior uveitis with again pars planitis and all of that. She tolerated MMF well. This is the most challenging case with the longest follow-up of 20 years. She's 41-year-old female, and she was known MS and major depressive disorder for 12 years before. 12 years later, she develops this uveitis, which was recalcitrant to mycophenolate, which was otherwise tolerated well in other cases. So we did intravitreal methotrexate once a week for 1 month in both the eyes. And since she responded well to methotrexate, we switched from MMF to 20 milligram methotrexate. This was a peripheral picture with snowballs and these stars showing pars periphlebitis, and this periphlebitis is known to be a marker for aggressive disease and protracted illness. Post-treatment, all this periphlebitis disappears and the snowballs also decrease in number, and these are representative MRI brain images with T2 hyperintense characteristic lesions perpendicular to the body of lateral ventricle. And this yellow arrow points towards a rim of hyperdense lesion with central hypo indicating the chronicity of MS. This is again T2 sagittal showing central hypodense with rim of hyperdense indicating chronicity. All these black holes which point towards again indicate chronicity. And this is atrophy of corpus callosum. This is a summary of all cases. So all females and both eyes were affected in mostly all. In spite of all the protracted illness, they maintained good vision. And anterior uveitis was in the form of granulomatous with mutton fat KPs, and it was intermediate uveitis with snowballs and peripheral phlebitis. The longest follow-up we had was for 20 years. And the uveitis developed either before or after MS in almost all the cases. This is to summarize all the findings. These were the neurological symptoms that we found: numbness in the toe, muscle weakness, fatigability, peripheral limb weakness, etc. And the systemic history and HRCT lab workup was all non-contributory of any other uveitic etiology. All the characteristic MRI lesions. but interestingly, one didn't show any MRI features, but that had CSF oligoconal blants. And all developed secondary steroid-induced or secondary angle closure glaucoma, and all of them tolerated MMF very well for many years. One recalcitrant, we tried methotrexate, responded well. Despite all this, all maintained good visual acuity. I thank Biswas sir and AIOC for the opportunity. Thank you.
It's a systemic test that you carried out. So, did you do a CRP and ESR and differential? Of course, you could have done.
Yeah, if all the workup, yes, sir. ESR, CRP, RA, ANA, ANCAs, all was done for the autoimmune part of it.
Yeah, but basically, you wanted to also rule out any infective etiology.
Yes. Like TB workup was done, MAN2, QTB, and HRCT chest. All.
Did you also do an OPGS tap and send it for PCR for some of these domains?
No, not really, because all the patients had MRI characteristic lesions, right? And the skin test and all of them was negative, so PCR was not mandated.
So if you look at your case number 3, that was the case where the MRI was normal to start with.
Yeah.
What in the granulomatous KPs did you find which made you think to do a CSF tap for that patient?
That was a previously tabbed patient which had come after, sir.
Means if
She
I
had
have to ask you
left
a
eye
question
optic-
that what are the findings on the anterior uveitis which will make you suspect that it is a case of a multiple sclerosis? Can you just tell me, enumerate some features which will help us?
Got it, sir. I think there are no pathognomic clinching anterior uveitis or in specific uveitis features that are marker for systemic conditions. It's only when others are negative and you have some neurological findings or something like that, that's when you do an MRI. It's not like you have any clinching pointers ophthalmologically, clinically.
In intermediate uveitis, anything that will make you suspect that there is
Retinal periphlebitis is one marker, ma'am.
where?
Other than
Where in the retina?
where, in any quadrant you mean? Quadrant.
Not quadrant.
I think peripheral retinal.
And you don't get any other cause, then you can think. What is the other condition which will produce the same picture? Intermediate uveitis, peripheral retinal vasculitis. You have ruled it out, but more common.
All other
conditions.
infections, it's tuberculosis, ma'am.
Non-infectious.
Non-infectious sarcoidosis, SLE.
Sarcoidosis.